I would like to invite the first speaker, Dr. Mayur Gharat from PGI Chandigarh.
Hello. I'd like to take a minute. The marking system has been designed out of 100 marks. Originality and creativity carries 20. The logical presentation, another 20 marks. The presentation and the quality of presentation delivery would be 20. The knowledge of the material, another 20. And neatness of the chart, 10 marks. And if you stick to your time, it would be 10 marks. So please try to stick to the time allotted.
Dr. Mayur will be presenting posterior C2-3 fusion with multiplanar realignment in unstable Hangman's fracture, a prospective study. If there is a slide of the institute, I think you just obviate that slide and don't disclose your identity as far as possible.
Thank you, sir. First of all, I would like to thank my mentors, the organizing team at AIMS Jodhpur, for this opportunity to present and to learn. I would like to present the rationale, techniques, and outcomes of posterior C2-C3 fusion with multiplanar realignment in unstable Hangman's fracture. So Hangman's fracture, as we all know, is the traumatic spondylosis of pars interarticularis, also defined as a bilateral fracture of C2 pars interarticularis. It has been further classified and treated depending on the displacement and relationship between C2 and C3. We are mostly focused on unstable Hangman's fracture here, which is Levine Edwards type 2 and above. So why posterior C2-C3 fusion? What are the other surgical options which are more commonly used? So different authors have recommended various surgical approaches with arguments in favor of each of them. Most commonly used are the anterior C2-C3 discectomy fusion, the pars pedicle screw alone, posterior C1 to C3 fusion, and combined approaches, occiputo-cervical fusion has also been used. So why not anterior C2-C3 fusion? Apart from the difficulty of exposure, risk of neurovascular injuries, the curvature and shape of the C2 vertebral body, apart from all these difficulties, the more specific issue in unstable Hangman's fracture is that the anterior fixation just realigns the C2-C3 translation anteroposteriorly. As we can see in the above two pictures, the fracture fragments are not displaced significantly and can be easily aligned. However, the lower three pictures where the fracture fragments are significantly displaced in various planes, just anterior fusion may not align them properly. Also, there have been studies where it has been shown that only anterior fusion in a long-term follow-up can give rise to local kyphosis as well as requiring repeated redo surgeries. Why not pars pedicle screw alone? It has been shown that pars pedicle screw alone is insufficient for C2-C3 translation more than 4 mm. In cases where there is intermediate translation between 4 to 8 mm, although the fracture site heals, there is persistent instability which can give rise to large osteophytes. It has also been demonstrated that the standalone direct pars fixation is insufficient to limit excessive flexion and extension. So why, coming back to the question, why posterior C2-C3 reduction and fixation? Now the posterior fixation addresses both the fractured fragments as well as the instability resulting from soft tissue injuries and are therefore better than the standalone pars pedicle screws. Biomechanically, it is a better construct. It can also address the fracture segment in multiple planes so as to achieve a good fusion. Various studies have shown that posterior C2-C3 fusion is better clinically and biomechanically as compared to C1 to C3 fusion in terms of both axial pain and neck disability. So we studied 12 patients of unstable Hangman's fracture in our institute. Clinically, patients were assessed in the terms of presenting symptoms, neurological status, and VAS score. Uh, we did a detailed preoperative radiological evaluation in multiple planes. As we can see in axial, we look for lateral translation, angular rotation. In coronal, we look for lateral translation, and in sagittal, we look for anteroposterior translation as well as overriding of the fragments. The surgical procedure, the approach was before the surgery, we did gave a gentle cervical traction which touch field tongs. However, excessive traction was avoided. The C2, C3 exposure was done in a standard fashion. C2 pars pedicle screws were inserted and lag effect was created so as to oppose the fragments. It was important to incorporate the proximal as well as distal fragments so as to achieve a good correction. And the correction was done in multiplanar type. To achieve anteroposterior reduction, the proximal fracture segment was pushed against the distal one, and during the tightening of the lag screw, reduction of anteroposterior translation on both sides corrected the rotational component. To correct the lateral translation, the distal fragment was pushed using an osteotome such that it comes in line with the proximal fragment, and they were fixed. At times when the fragments were interlocked, overriding, osteotome was used to manipulate and distract the fracture segment and followed by placement of C3 lateral mass screws. Bilateral C2, C3, bilateral C2, C3 joints were drilled and bony fragments were placed so as to achieve good fusion later on. The procedure was done in OM guidance. Immediate postoperative plain radiographs and CT scan was done. Philadelphia collar was given for at least 3 months post-op, and 6 and 12 months follow-up CT was done. So the key factors in multiplanar realignment of the unstable Hangman's fracture are preoperative gentle cervical traction, intraoperative manipulation, and creating a lag effect. The outcomes, as you can see, the various malalignment in the various planes, we achieved a fusion in all our patients. There was no change in the neurological status of the patient. However, there was a significant reduction in the pain score. Sorry, sir, there's some technical problem. Next. Next neuro. Yes, sir.
There is 1 Whether he wants to give it for discussion or not,
Sir, I'll finish in next 15 to 20 seconds actually, sir.
start when your slide is projected.
Sure. Hmm. So actually still there's some problem. I will just finish it.
Go ahead.
Actually it is still stuck, sir. I'll just finish it using, yes, sir. No, no, still the next slide will not come. It is not coming, sir.
Okay, you speak then.
Yes, sir. So various studies have shown that good fusion and alignment can be achieved using posterior C2, C3 fusion. However, these studies have not described the malalignment of fracture fragments in various planes. In our studies, two patients noted to have a mild kyphosis postoperatively. Possibly it could be due to fusion of C2, C3, which is a junctional zone between CVJ and subaxial spine. Limitations of our study were the small number of patients. There was no comparable arm with anterior approach. Apart from the posterior approach related complications, the technique described to create the lag effect and the multiplanar realignment needs expertise. So to conclude, posterior C2, C3 fusion appears to be an effective method to deal not only with the fractured segments, but also the associated disco-ligamentous instability. It can achieve good realignment of the bony fragments in all planes. Thank you, sir.
One question. Yes, please.
Yes, sir.
So why C3? It's an innocent bystander.
Uh, to the first question, sir, the we are using
In what subset of patients
sir.
are you using C23 fixation?
In the patients where after preoperatively radiological assessment, we see that the fractures are in multiple planes, which cannot be, the fusion, the realignment cannot be achieved with, without aligning the fractured fragments. In those cases only we are using posterior C2, C3
So the
fusion.
answer to this question is that it is a type 2B hangman's where there is a C23 discal disruption, and possibly type 3 hangman's where there is a C23 subluxation of facets where you require a fixation of C3 also along with C2.
Yes, sir.
In type 1 and type 2 fractures, you need not fix C3.
Yes, sir.
Okay?
Thank you, sir.
I would now like to invite Dr. Venkatesh.
Good morning, sir. I thank AIMS Jodhpur for giving me the opportunity to present. I'm presenting ACM type 1, that is we have proposed a SVIMS algorithm. So as we know, the origins of both the syringomyelia and its CSF buildup remain unclear. Most studies suggesting that the cause is altered CSF dynamics at the level of craniocervical junction as a consequence of tonsillar occlusion. And the goal of surgery is mainly focused to provide enough subarachnoid space at the level of foramen magnum. The commonly followed surgical methods are FMD alone, FMD with duroplasty, FMD with arachnoid adhesive lysis and lax duroplasty, FMD with tonsillar resection, pexy and lax duroplasty, FMD with any of the above and additional removal of C1 and C2 lamina, and FMD with syringo-subarachnoid shunting. Although posterior fossa decompression has high success rate in re-establishment of CSF flow and normalization of posterior fossa crowding, syringes fail to resolve in around 10 to 40% of the cases. Recently, stabilization of the atlantoaxial joint was proposed based on the possibility of instability at the atlantoaxial joint as the cause for syringomyelia. So, in our institute, 102 patients with symptomatic type 1 ACM with syringes were underwent surgical management from 2014 to 2020. Among these, 40 underwent FMD alone, 18 underwent FMD with syringostomy, 32 C1C2 fusion, and 12 underwent C1C2 fusion with joint spacer placement. The following parameters were studied: age, duration of symptoms, sagittal foramen magnum diameter, posterior fossa volume, change in atlantodental interval from flexion to extension on dynamic CT, and MRI CSF flow studies at foramen magnum level. Initially, FMD was standard of management, but duroplasty was not preferred as it was associated with increased postoperative complications in the form of CSF leak, meningitis, and longer hospital stay. For large syringes, we used to do syringostomy initially. Even though it reduced syringes rapidly, symptomatic improvement was not good, and it was also risks of neurological deficits developing from their placement, delayed cord tethering, occlusion, and malfunction over time. So syringostomy was stopped, but the results were included in this study. Out of the 1 or 2 patients, 60 patients were improved symptomatically on a 1-year follow-up. The highest improvement in symptoms being in the C1C2 fusion group, that is 81.25%. The demographic data was studied, and in FMD group, improved and not improved were compared, and it was found that age, duration of symptoms in the sagittal FMD, posterior fossa volume, and change in ADI was less in the patients with improved group. Similar data was compared in FMD with syringostomy in C1C2 fusion group and CNC2 with joint spacer group. And then we compared the results of improved patients in FMD and patients who are not improved with C1C2, and also patients who improved in FMD and patients who who did not improve in FMD and who improved in C1C2 fusion group. ROC curves showed less sensitivity and specificity for the factors. It was clear that not a single factor could effectively determine the prognosis, so all factors had to be considered while deciding the optimal surgical procedure to get the results. All 4 groups had improvement of symptoms in some patients and non-improvement in some patients. Based on these observations, we proposed an algorithm for the management of ACM. ACM patients were categorized into 4 groups, that is only ACM, with AD and BI, and with BI. Diagnosis was made radiologically, and the factors considered in the algorithm were sagittal foramen magnum diameter, change in atlantodental interval from flexion to extension on dynamic CT, posterior fossa volume, and CSF flow study at foramen magnum. This was the algorithm we proposed based on MRI. So if there is ACM with no AAD or BI, we checked for change in ADI. If it is greater than 0.8 mm, then and abnormal flow is present, then we underwent C1C2 fusion. The summary of this algorithm can be seen in this table, that is the 4 groups of patients, that is only ACM, only BI, BI with AD, and only AD, along with the abnormal CSF flow, decreased posterior volume, or decreased sagittal foramen magnum diameter, were divided into different groups, and they underwent the surgical procedures. So these are some of the examples which we did according to the algorithm. So here in this case there was no AD or BI. Change in atlantodental interval was not greater than 0.8 mm. There was abnormal CSF flow, posterior fossa volume was less. So they underwent FMD, and this case was only ACM type syringes with no AD or BI. So coming to conclusion, not a single factor independent useful in deciding the type of surgical approach. Choice of surgical approach should be made after considering all the factors. And the limitations of the study were majority of the data is retrospective, prospective validation is required, and it needs testing in the form of much larger multi-center studies. Sir. Thank you, sir. Sir, clinical improvements. A Chiari malformation.
So A stands for what?
Arnold.
No, man. That's all outdated, man. The ACM is adult Chiari malformation. Understand?
Yes.
Arnold Chiari name is no longer
Yes.
there.
Yes.
Should have at least checked that.
In 12 patients, you put spacer.
Sir?
Spacers were inserted in 12 patients.
Yes,
Why?
sir.
Because there was no BI in any case.
Sir, spacers were inserted in 12 patients, sir.
What was the purpose of inserting a spacer when there was no BI?
It's for stabilization.
Thank you.
Thank you, sir.
Mohit wants one
Sir,
announcement.
we'll break for 2 minutes. We'll just take a quick group photograph, and then we'll resume the award paper session.
Okay.
Because some of the faculties have to leave right now, sir.
Yeah, please.
So I please invite all the faculty and all the delegates to the stage for a quick group photograph.
टेलीमेडिसिन में आ रहे हैं ओपन करके देखो एक बार खुल जाएगा
कॉपी कर
नाम से
Last number. चालू करना है चलो रुक